share my project of predicting sepsis with you. Sepsis is the leading cause of deaths in hospitals. Most of the cases originate in the community and not in the hospital. 35% of in-hospital deaths are due to sepsis. Sepsis kills more people annually than stroke, prostate cancer, breast cancer, and opioid overdose combined. So what is sepsis? The term sepsis has been used to refer to the presence of microbial toxins in the blood. However, we now know that sepsis can be the consequence of bacteria, virus, fungal, or parasitic infection. We now understand that sepsis is the result of a dysregulated host response to infection accompanied by life-threatening organ dysfunction. Early prediction of sepsis is crucial in preventing mortality, given that sepsis management is highly time-sensitive. Of course, I have to go into a little bit of the pathophysiology. The pathophysiology of sepsis involves an evolving process. The following shows the process of how sepsis works. Microorganisms invade the body tissues and the patient exhibits an immune response. The immune response provokes an inflammatory response. There is increased capillary permeability, and vasodilation interrupts the body's ability to provide adequate perfusion, oxygen, and nutrients to the tissues and cells. The inflammatory response activates the blood clotting system. The imbalance of the inflammatory response are critical elements of progression of sepsis in affected patients. Okay, human predictors. I will make this slide deck available so you can review the tools later at your leisure. A tool is implemented when a patient is already critical and they are done at the bedside at specific intervals. Specific tools may be forgotten to be completed as ordered and may be miscalculated by human error. They may not be communicated to anyone by mistake. These are some of the programs embedded in the electronic health record, but delays in communication still occur. A delay in communication among clinicians, nurses, and pharmacists exacerbates delay in sepsis management. The early prediction of sepsis before its onset in a patient gives clinicians additional lead time to plan and execute treatment plans. Let's see if this is going to work. We're just going to take a look at one of these tools right here. So this is the Apache 2 tool. This is an example. This tool serves as an early warning indication of death and prompts clinicians to upgrade their treatment plan. 3 key factors make up the scoring: acute physiologic score, age scores, and chronic health scores. A lower Apache 2 score, the higher the chance of survival. The Apache 2 score is calculated at the beginning of the intensive care unit admission to help determine the patient's mortality for the admission. Okay, this is an evidence-based research bundle. Once you have your diagnosis for sepsis. For sepsis and septic shock, these are the interventions that you want to institute at the earliest time. Measure lactate level. Lactate is a measure of tissue perfusion that indicates how cells are being oxygenated, regardless of the blood pressure. Lactate is produced when tissues are not adequately oxygenated. Severe lactic acidosis can develop in minutes, so frequent monitoring of serum lactate levels for shock are often necessary. You want to obtain blood cultures before administering antibiotics, administer broad-spectrum antibiotics, begin rapid administration of intravenous fluids for hypotension, and apply vasopressors if hypotensive during or after fluid resuscitation to maintain a mean arterial pressure of greater or equal to 65 millimeters of mercury. For those with respiratory failure, high-flow nasal oxygen should be used. Okay, blood cultures. Obtaining blood cultures prior to the administration of broad-spectrum antibiotics is necessary. The culture and sensitivity will take about 48 hours, so do not delay your administration of broad-spectrum antibiotics. Timing of antibiotics. Administer the prescribed antibiotics. Infuse the antibiotic that goes in over the shortest time period, which is about 30 minutes, first, and then the ones that take longer. Vancomycin, which you all may be familiar with and have heard of, takes about an hour plus to infuse, so you don't want to start with a vancomycin infusion. You might be thinking about someone that has a penicillin allergy, so for someone that has a penicillin allergy, the aztreonam is the drug of choice. Okay, intravenous fluids. You'll need fluids to maintain blood flow to your organs and prevent your blood pressure from dropping too low. A 30 ml per kilogram IV fluid bolus for fluid resuscitation is recommended to begin within the first hour to stabilize sepsis-induced tissue hypoperfusion. Isotonic is the fluid of choice. Isotonic fluids have a similar concentration of electrolytes as blood plasma. Isotonic solutions are designed to increase extracellular fluid volume. Vasopressor is a drug that is used to make sure blood vessels constrict or become narrow in people with low blood pressure. These are people in shock, and they are unable to get enough blood to their vital organs. Vasopressors make your heart have a more forceful contraction, and norepinephrine is the drug of choice. Vasopressors should be initiated within the first hour when fluid administration is not sufficient to achieve the hemodynamic resuscitation goals. Through my review of the literature, I found several articles of interest that discussed artificial intelligence and machine learning in healthcare. Not many articles were found in the nursing literature. I have included 3 articles that I found of interest. A review of these articles is at the end of my presentation. Early prediction and diagnosis of sepsis, which is critical in reducing mortality, is challenging as many of the signs and symptoms are similar to other less critical conditions. By now, it should be apparent that an AI-derived algorithm which could accurately predict sepsis at a very early stage would be extremely valuable. The review of the literature provided a proof of concept that an AI algorithm should be able to accomplish this. We have obtained access to the Medical Information Mart for Intensive Care, abbreviated as the MIMIC3 database, and have consulted with experienced clinicians for the development of a more accurate predictor using multiple clinical variables and non-quantitative data from the data set. The MIMIC3 is a large single-center database comprising information relating to patients admitted to critical care units at a large tertiary care hospital. The database supports applications including academic and industrial research, quality improvement initiatives, and higher education coursework. Prospective quantitative variables for the next stage of my research are on this slide. And I would plan to use natural language processing to analyze large amounts of clinical notes, such as admission notes, progress notes, and discharge notes. And to wrap things up, since this was an interdisciplinary project, Maj, who is a summer research intern, worked with me on my project. And he was invited to a suturing skills day event and learned how to throw a few sutures into the simulated skin under the direct supervision of a general surgeon. These are my references. This is my contact information, and to follow this slide is the literature review of the 3 specific articles that I found of interest. Thank you very much.